Beyond the trip, beyond the haze, we're letting up these shadow waves. Ketamine dreams to...
Welcome back to Conscious Healing, Beyond the Trip, hosted by Dr. Jason Harris. Each week, Dr. Harris explores the world of ketamine and other psychedelics, uncovering how they're helping to treat mental health conditions and chronic pain disorders.
This podcast is intended for educational purposes only. The information shared should not be considered medical advice. Always consult with your physician or a qualified healthcare professional before making any changes to your medication or treatment plan. Please be aware that some of the substances and treatments discussed on this podcast may be illegal in certain jurisdictions. We do not endorse or encourage the use of illicit substances. All right, welcome back to Conscious Healing Beyond the Trip. I'm Dr. Jason Harris. I'm coming to you with a special episode today. This is just a bonus episode. We still have our typical weekly episode coming out on Thursday. The Alabama State Medical Board put out a position statement this month regarding their recommended use of ketamine for treatment-resistant depression or treatment-resistant mental health disorders. What a position statement is, this is a recommendation by the state medical board on how physicians should practice. It's not a law. They're not going to prosecute you if you don't follow these rules, but if something bad happens, they can go back and be like, hey, we have a position statement and you weren't following their recommendations. Usually when a state medical board puts out a position statement for a patient safety issue like this, then they do follow that up very quickly with a law that needs to be followed. So I'm going to go through what the Alabama State Medical Board put in their position statement, and then I'm going to go over what Texas currently has in their recommendations. They don't have a position statement yet, but we'll go over that at the end. So the first thing that they talked about is who can prescribe ketamine for treatment-resistant mental health disorders. It's only physicians. Only physicians can prescribe and administer ketamine for treatment-resistant depression. They also recommend that if you're not a psychiatrist, the diagnosis of treatment-resistant depression must be confirmed by a psychiatrist. A lot of these rules follow closely with insurance and FDA regulations on the use of Spravato. So if you know anything about Spravato, the nasal spray that's FDA approved for major depression, you'll notice that a lot of these recommendations are the same recommendations that we're following with Spravato. The patient must have a diagnosis of major depression as defined by the DSM-5 or major depression with suicidal ideations. Ketamine is not a first-line drug. They want the patients, just like with Spravato, to have tried and failed at least 2 antidepressants from 2 different classes. The antidepressants have to be an adequate dose and an adequate duration. Usually that's a recommended, the highest recommended dose for at least 6 weeks. Obviously, if the patient was having side effects, that can still be used, but you just have to note that they stopped the antidepressant because of side effects. Physicians have to use a standardized depression scale to follow the patient's progress and to ensure that before treatment is started that they have a diagnosis and they're actively depressed. Exclusion criteria. Patients should not be administered ketamine if they have a diagnosis of schizophrenia, schizoaffective disorder, any patients with uncontrolled hypertension, pregnant patients, any patients who's had a severe or serious side effect from ketamine in the past, any patient that has a history of ketamine use disorder, and they have a disclaimer that you should use extreme caution in patients with an active substance abuse disorder. They also recommend to never give ketamine to patients who are acutely intoxicated. So they've put some required medical screenings down. You have to obtain consent, and in that consent, you have to let the patients know that ketamine is being used in an off-label fashion for treatment-resistant mental health disorders. You have to do a history and physical, and included in that history and physical, you have to document previous antidepressant use, a physical exam. Every visit, the patients have to have a urine drug screen, and you have to obtain consent prior to administration. Now, it doesn't say whether this can be a blanket consent at the beginning of all treatments or if this needs to be done at every visit. I'm sure they'll expand on that at some point when questions come up. You can only prescribe the minimum dose necessary to achieve desired effects. So no more of this rogue ketamine clinics just giving doses willy-nilly as much as they think is appropriate. Requirements for location, administration, and monitoring. This is a big one. The space should be large enough to accommodate the patient and required personnel, so the doctor and the nurse. Facilities should have the means to monitor heart rate, blood pressure, respiratory rate, oxygen saturation. You have to have oxygen and medications available in case there is a bad side effect. The patient stops breathing or they have a hypertensive emergency. Those medications have to be on hand. Now, while they didn't specifically list out certain medications, they could in the future come back and say, oh, hey, we've got to have this specific medication there or not. There has to be a crash cart immediately available in case there was a cardiac event or a respiratory event. The prescribing physician has to be ACLS certified. So ACLS is advanced cardiac life support. You learn how to resuscitate patients if they have a cardiac event or a stroke or something like that. And they have to be trained to establish an airway if necessary. And this is a big one because not all physicians who practice medicine have done or learned or trained to establish an airway. So whether this is a psychiatrist and then you have a CRNA, or whether it's like myself, an emergency physician who is ACLS certified and has been trained and performed thousands of airways over my career. You can have other licensed professionals there, nurses, CRNAs, and they can assist in the administration of ketamine, but it specifically says the physician must be on site at all times that ketamine is being given. So it can't be a nurse practitioner who runs the clinic while the physician is out of the clinic. And it specifically can't be a CRNA, which is what a lot of clinics do have at this point. All licensed professionals that are there, so your nurses that are there or your CRNA or whoever else is there assisting, have to be ACLS certified. The patients, this is a big one. Patients must be monitored for at least 2 hours with vital signs checked every 5 to 15 minutes. That's a big one because right now, a lot of clinics, including myself, we don't watch a patient for the full 2 hours. Once their treatment is done after about an hour, we have another 15, 20, 30 minutes there once the patient is fully awake and at their baseline, able to ambulate on their own. We do discharge the patients after that. So that could make some clinics have to adjust things to make sure that they're following these rules. Their next recommendation was a PHQ-9, which is a standardized depression scale, 9 questions administered to the patient, has to be performed at each visit, and the physician should discontinue the use of ketamine if the patient does not show improvement after 4 to 6 infusions. Now, I do not like this rule specifically because sometimes it does take 8 or 10 of the initial doses before we notice an improvement. So I think that one's a little excessive. Even with Spravato, they give you, 8 to 10 treatments because that depression scale looks back on how the patient's been doing over the last 2 weeks. And if you're giving 6 treatments, over 2 or 3 weeks, now we'll get to that because they do have some rules on or recommendations on how often ketamine should be given. But 2 or 3 weeks, they're just in their first or second treatment when you're going back and asking the questions. So I don't really like that one. Maybe there's some interpretation that can be made there or changes that can be made there. They do recommend that treatment with psychotherapy be considered in tandem with ketamine treatments. Highly recommend this. We don't currently have this in our office. We're going to be currently hiring a psychotherapist that can do ketamine-assisted psychotherapy because it 100% works better if you do the treatment and go straight into a therapy session or even a therapy session during the treatment as long as the dose is low enough. All right, next thing they talk about is the dosing and the titration of the dosing. It says that the physician should be the one determining the appropriate dosage. They do recommend that 0.5 milligrams per kilogram over 40 minutes be the recommended dose. That is the minimum therapeutic dose in all the studies. They do leave you the option to increase, but it does say higher doses may be more likely to result in adverse effects. As you go up on dose, blood pressure can increase. You can have a dissociative event where the patient could get upset and freak out. So that is, again, some patients do need higher doses than the 0.5 milligrams per kilogram. So I think that's a little restrictive, but it doesn't specifically say that you can't go up. It just says that higher doses can result in adverse effects. The next one that I 100% do not agree with, it says infusions should not be given more than twice a week. Most of the studies that are being done, you're given 3 treatments, like a Monday, Wednesday, Friday. My recommendation is always to have 24 hours in between a treatment if at all possible. So going back to 2 times a week, I've not seen the protocol where we do, twice this week, twice next week, once the next week, once the next week. I've not seen that one in my clinic work as well as doing 3 one week, 3 the next week, and then taking a break. We'll just have to wait and see if, how that plays out also. I'm sure there's going to be a lot of pushback or feedback from the physicians in Alabama about this. Safety precautions. Ketamine should never be given at home. I've been screaming this for ever. These online companies that are selling patients at home ketamine, not monitored. There's nobody there to make sure that they're not going to have an adverse event. So this is a big one. There are patients who just do at-home ketamine. And again, it's dangerous. We do offer an at-home ketamine, but my patients have to have had multiple treatments in the past showing that they've not had any issues, and then we can discuss it. But again, I've actually put a stop to that in my clinic. We won't be doing troches, the at-home ketamine, for any new patients because of, the FDA also came out and said it shouldn't be done. So we're starting to scale that back at Transformative Wellness. Infusions should immediately stop if there's any significant increase in blood pressure, heart rate, the patient develops shortness of breath, wheezing, or any other cardiac involvement. That's a no-brainer. We're already doing this. I would hope that all clinics are doing this. If you have a patient have an issue, you should immediately stop the treatment and assess the patient. Patient can't operate a vehicle or heavy machinery for 1 sleep cycle. So that's a no-brainer. Also, you go home, you go to bed, and then the next day you should be good to go to work or drive vehicle. The next one says patient must be driven home by a caregiver. I am unsure if Uber or Lyft, one of those rideshare companies, is considered a caregiver, but we have a lot of patients who don't have a driver, who don't have a safe way to get home, and they do utilize Uber or Lyft. My clinic specifically, we watch those patients for an extended period of time to make sure they're 100% able to ambulate on their own and not going to have any side effects. What is this going to mean for ketamine clinics or patients receiving ketamine in Alabama? I suspect that you're going to see some clinics closing down because they're owned or run by a nurse practitioner or a CRNA, and their specific recommendations now are a physician has to be in the building. If you're currently receiving oral ketamine treatments by one of these online companies, you probably won't be able to receive that anymore. This just came out last week, so I'm sure there's going to be a lot of debate, and we'll see what happens with it. What does this mean for Texas? Texas does not currently have a policy as of August 2025 that discusses low-dose ketamine for mental health disorders. As of August 2025, January of 2025, the Texas Medical Board did put out a statement and said that ketamine, low dose or anesthetic dose, you have to follow all rules covered under office-based anesthesia. And that's a big one because only physicians can administer office-based anesthesia. So, nurse practitioners and even CRNAs cannot administer office-based anesthesia. So that's a big rule. Texas Medical Board has committed to doing a comprehensive review of low-dose psychotropic ketamine uses for mental health, and I suspect they're going to follow in Alabama's footsteps and put out a similar statement. So we'll just have to wait and see what happens over the next 6 to 12 months. It says all in Texas, this is, again, under the office-based anesthesia rules, All ketamine clinics must be owned by a physician, and the physician must be present in the clinic at all times that IV ketamine is being given. You can have a CRNA or a nurse assist you with that, but again, a physician has to be in the building at all times that IV ketamine is being given. As far as its legal status, ketamine is considered off-label for mental health disorders, and it must be supervised by a physician, and you must follow all office-based anesthesia rules, which we have been for years here at Transformative Wellness. There have been some clinics that have successfully argued that low-dose ketamine is not office-based anesthesia, and they were successful. It does set a precedent about how they may interpret things moving forward, but we'll just have to wait and see. Always remember, this podcast is not medical advice. It's a conversation, one that's evolving. Talk to your doctor, ask the hard questions, but remember, your provider might not be up to date on the latest research and might be closed-minded to the use of psychedelics, even though the science is there. Stay skeptical, stay open-minded, because sometimes the most healing paths are the ones we nearly forgot. Thanks for joining me on Conscious Healing Beyond the Trip. I'm Dr. Jason Harris. Until next time, stay curious and stay informed.